Hi, I'm Chao-Wei Hwang from the Johns Hopkins University School of Medicine and Frederick Health Hospital. Today we're going to talk about a recent bifurcation PCI case in which the side branch became completely flush occluded. We'll talk about different techniques we used to get it back. The patient is a 65-year-old woman with hypertension and a history of CAD and LED stenting, who presented to our hospital with chest pain and eventually ruled in for a non-STEMI. On Cath, the RCA had mild disease. The LED had a widely patent stent and only minor irregularities. The circumflex is shown, and we clearly see the culprit. There is a true Medina 111 bifurcation lesion involving the bifurcation of the circumflex and the OM. So we went to work. Both branches were similar in size and were both severely diseased. So I thought that there was a good chance that we would need to have to stent both branches. I wired both branches fairly easily with workhorse wires and ballooned the OM with a small 2.0 millimeter compliant balloon. Next, I gently ballooned the circumflex as well. I kept the balloon small and the inflation pressures low to reduce the possibility of dissection. Okay, so here is how things looked after angioplasty. Both branches look better, and there is no big dissection, just as we intended. So what next? What is our stenting strategy? Well, as many of you know, I am a big fan of tap stenting, but the bifurcation angle here is just too narrow, making this not a very suitable bifurcation for tap. I'm also not a big fan of crush techniques in general. I never liked the idea of having 3 layers of mangled struts taking up space in the blood vessel. So I typically only go to DK crush in large vessels such as the left main or very proximal bifurcations. For smaller vessels, I generally don't use crush. But here, both branches are comparable in size, and I thought a Culotte technique would actually be quite suitable. So we decided to use a true Culotte technique. I have a couple of videos that go over Culotte in detail, and I've included the links in the section below. So we went ahead and stented the more angulated branch first, in this case the OM, with a 2.75 by 18 millimeter DES. In Culotte, it is really key to take the time to post-dilate your stent aggressively before trying to rewire the other branch. Otherwise, you risk rewiring underneath your new stent and causing all sorts of problems. So we went ahead and post-dilated our stent with a 3.0 millimeter non-compliant balloon at high pressure. I normally pull my side branch wire out before post-dilating. This is to avoid getting the wire trapped by your new stent, especially if the lesion is complex or calcified, and this would be a terrible complication. But sometimes if I'm really worried about the side branch, I will leave the floppy tip of the wire in. In this case, I pulled the wire all the way out, and in retrospect, this might have been a wrong move. So here is where we stand after the first stent. The OM looks fantastic, but the rest of the circ is gone, and it's flush occluded, not even a stump. And because I pulled my wire completely out, we can't even tell where the circ continuation was. So this is quite unfortunate, and I kicked myself for not leaving the floppy tip of the wire behind. So my first move in this case is to try to rewire the side branch using the old wire. I find that this works more than half the time. Somehow a wire that has already been in the branch usually finds its way back. It's almost as if the tip has a memory. The tip probably just has the right angle. But in this case, it did not work. The old Pro Water could not find the rest of the circ. I next tried a hydrophilic Pilot 50 wire, which is my usual next move, but that didn't work either. So presumably the ostium of the circ is covered by shifted plaque. So I went to a heavier hydrophilic wire to see whether we can puncture through that plaque or at least scrape along the vessel to partially move the plaque out of the way. I went to a Pilot 200 wire and passed it through the side port of a twin-pass dual-lumen catheter. The side port opening can be directed toward where you think the ostium of the side branch was, and this can sometimes facilitate wire entry into that side branch. So this is what things look like after trying for a while with the Pilot 200 and the twin pass and scraping all along the bottom wall of the vessel. Unfortunately, no progress at all. It is still completely flush occluded, and I could not even tell where to poke. So I decided to reach for IVUS. I thought that this would allow me to at least see where the side branch was and potentially allow me to wire into the side branch under direct IVUS guidance. So here is the IVUS. You can see the occluded circumflex coming in and out of the picture at around 7 o'clock. And clearly it's been covered by a thick rind of plaque. I tried to get my Pilot 200 to puncture into that side branch under direct IVUS guidance, and this often works quite well actually in larger vessels where there is plenty of room for the wire to be maneuvered around the IVUS catheter. But in our case, the IVUS catheter actually took up most of the space in the vessel. And I tried and tried, but had a hard time getting the wire to the correct position to puncture the cap in the side branch. But here we are after my attempts to wire under IVUS. We were not able to get into the circ, but I did manage to scrape off enough of the shifted plaque that you can see the circ is now actually ghosting in. So we can now better tell where to poke. Now that we can kind of tell where the circ is, I decided to reach for a 120-degree angled supercross catheter. These catheters have a preformed angled tip that allows you to cannulate tough side branches. It'll give you additional backup that can help you get your wire down. The angled supercrosses come in various angulations, but I've really only found the 120-degree flavor useful. The tips of these catheters do tend to straighten out, especially in smaller vessels. So I found that the smaller angled tips generally don't work as well. And this actually worked. A Pilot 200 wire sailed down the circ via the 120-degree angled supercross. And you can see that the supercross catheter itself dislodged enough plaque that a small channel is now reestablished. The rest of the PCI now just involves completing the culotte, and that was actually fairly straightforward. I ballooned the circ with a 2.0 millimeter balloon, stented with a 2.5 by 15 millimeter DES, and sequentially post-dilated with 2.5 and 3.0 millimeter non-compliant balloons at high pressure. Again, key point, aggressively post-dilate, especially the proximal part of the stent in culotte before rewiring the other branch. We did kissing balloon angioplasty and final pot. And here is the final angiographic result, which I thought was quite nice. The rest of the patient's hospital course was uneventful, and we sent her home the following day on aspirin and prasugrel. All right, take-home messages. So side branch occlusions unfortunately still happen even with your best efforts to protect it. Side branch flush occlusions are even worse. I generally pull my side branch wire out before post-dilating to minimize the risk of trapping the side branch wire. But if your side branch is tight, consider leaving the floppy part of the wire in the side branch. The risk that the floppy part of the wire could get stuck is smaller, and this probably would have helped in this case. If your side branch does become flush occluded, IVUS is helpful for locating where it is. And if your main branch is large enough, you might be able to puncture into the side branch under direct IVUS visualization. Finally, reach for the angled microcatheters and the dual-lumen microcatheters. These catheters are not used very often, but they can really make your life easier when you need to access difficult side branches. Thank you for watching.